Hello, everyone. Welcome to the first press conference for the World Conference on Lung Cancer. I'm Matthew Smeltzer, Associate Professor at the University of Memphis and incoming chair of the IASLC Communications Committee. One of the roles of our committee is to host a press conference every day here at World Conference. Thank you for being here today. Today we also have patient advocate Ms. Meryl Hennick with us to respond to some of this exciting research. So we're going to hear from some of the exciting research that's going to be presented at the conference today, this week, here today at the press conference. Please hold all of your questions until the end. Our first presentation is from Dr. Wenfeng Fang, who's professor of medical oncology at Sun Yat-sen University Cancer Center in the city of Guangzhou, Guangdong Province, China. Dr. Fang will present the summary of his team's research on abstract 2114, a phase 1-2 study of Iza-Bren, a monotherapy in patients with locally advanced or metastatic EGFR-mutated non-small cell lung cancer. Welcome.
Hello, good afternoon, everyone. I'm Wenfeng Fang from Sun Yat-sen University Cancer Center in Guangzhou, China. It's my great honor to be here to share our results. I will present this oral presentation today after tomorrow. And this afternoon, I will share with you the key information about our study. It's a phase 2 study of Iza-Bren as monotherapy in patients with locally advanced or metastatic EGFR-mutant non-small cell lung cancer. I have no conflicts of interest to declare. The Iza-Bren is in potential first-in-class. So the Iza-Bren is a potential first-in-class ADC comprised of EGFR-3 bispecific antibody conjugated to a lower topo-1 inhibitor. The DR was about 6 or about 8. In this study, we updated the latest efficacy and safety of Iza-Bren in pretreated EGFR-mutant non-small cell lung cancer patients from a phase 1 and a phase 2 study. All patients received Iza-Bren at 2 to 3.5 milligrams per kilogram day 1, day 8, Q3 weeks, or 3.5 to 6 milligrams per kilogram day 1, Q3 weeks. As data cut off, there were still 26 patients on treatment ongoing. In this afternoon, I will just check the key information of efficacy of Iza-Bren at 2.5 milligrams per kilogram day 1, day 8, Q3 weeks. This dosage was chosen as the up to D dosage. Total there were 121 patients for efficacy analysis. In patients treated with Iza-Bren at 2.5 milligrams per kilogram day 1, day 8, Q3 weeks, the confirmed objective response rate was 49%. The median PFS was 6.9 months. The median OS was 24.8 months. In post-TKI and chemo-naive patients at 2.5 milligrams per kilogram day 1, day 8, Q3 weeks, the confirmed objective response rate was 56%. The median PFS was 12.5 months. The median OS was not reached. The efficacy in the post-third generation TKI and chemo-naive patients was comparable to that in the post-TKI and chemo-naive patients. This is the depth and the duration of response in post-TKI and chemo-naive patients. 94% of patients with tumor shrinkage and the median shrinkage was about 39%. The median duration of response was 13.7 months. This is the PFS and OS curves in post-TKI and chemo-naive patients. The median PFS was 12.5 months. The median overall survival was immature. 18 months OS rate was 69%. And we also did the analysis, subgroup analysis in post-TKI and chemo-naive patients by different EGFR subtype. You can see the comparable efficacy was observed in patients with different EGFR subtype. Let's move on to the safety profile. Most common grade 3 and above treatment-related AE were hematologic toxicities, which were effectively managed with standard supporting care. Only one case of G1 intestinal lung disease was observed. No new safety signals were identified. In conclusion, in previously treated EGFR-mutant non-small cell lung cancer patients, Iza-Bren demonstrated promising efficacy with a manageable safety profile. In post-TKI and chemo-naive patients, the objective response rate was 66%. The confirmed objective response rate was 56%. The median PFS was 12.5 months. The median overall survival was not reached. In post-TKI and chemo-naive patients, comparable efficacy was observed in patients with different EGFR subtypes, which was consistent with the total population. A phase 3 registrational study of Iza-Bren as monotherapy in EGFR-mutant non-small cell lung cancer after progression on a third-generation TKI is ongoing in China. Thank you. Thank you for your attention.
Thank you for that excellent presentation. Very exciting data. So up next, we have Dr. Fei Zhao, and Dr. Zhao is Chief Physician Associate Professor at the Department of Medical Oncology, Shanghai East Hospital. And Dr. Zhao is presenting on the same drug. So he has a phase 2 trial of the same drug, separate trial. We're really excited to have these two abstracts here together at the World Conference. So he's presenting on abstract 1742. This is the phase 2 study of Iza-Bren combo with Osimertinib in EGFR-mutated locally advanced or metastatic non-small cell lung cancer. Dr. Zhao from Shanghai East Hospital.
Hello, everyone. My name is Fei Zhao from Shanghai East Hospital, Tongji University. It's also my great honor on behalf of my study team to report the preliminary results of the phase 2 study of Iza-Bren in combination with Osimertinib in EGFR-mutated locally advanced and metastatic non-small cell lung cancer. Here's my disclosure of conflicts of interest. Here is our phase 2 study that investigate Iza-Bren's novel EGFR-HER3 bispecific ADC in combination with Osimertinib in treatment naive EGFR-mutant non-small cell lung cancer, and eligible patients has ECOG performance of 0 to 1 and has memorable disease persist version 1.1. And all patients were treatment naive to receive the Iza-Bren in combination with Osimertinib. And as the date cutoff of June 13, 2025, a total of 154 patients were enrolled into our study, including 5 cohorts, including 2.2 milligram kilogram day 1, day 8, Q 3 weeks, or 2.5 milligram or 2.75 milligram day 1, day 8, Q 3 weeks strategy, or 4.0 milligram or 4.5 milligram day 1, Q 3 weeks strategies. And at the date cutoff, 111 patients were still on our treatment, and the primary endpoint was recommended phase 2 dose and objective response rate, and the secondary endpoint including progression-free survival, DCR, DOR, and safety profiles. Here is our preliminary efficacy all patients who received the D1 date Q3 week dosage, especially at the dosage of 2.5 milligram kilometer Q3 weeks, nearly all patients respond to our combination therapy with an objective response rate of 100%, with a confirmed objective response rate of 95%, and still 2 patients with partial response are waiting for confirmation. Due to the limited follow-up time for progression-free survival, the median progression-free survival has not reached. Here is the depth and the duration of the response at the dosage of 2.5 milligram kilometer. We can see from the waterfall plots that nearly 100 all the patients respond to our treatment, and the median tumor shrinkage was 56.7%. Here is the swimming plots that show the depth and the duration of the response at the same dosage. We can saw from the plot that the depth of the response was really deep, and the duration of the response was durable. Also, due to the limited follow-up time for the duration of the response, and the duration of the response has not reached yet. Regarding treatment-related adverse events, most common adverse events were hematological toxicity, including anemia, leukopenia, and neutropenia, and thrombocytopenia. Notably, most common grade 3 or above AE was neutropenia, and the neutropenia leaded to dose reduction was 11.4%, and leading to discontinuation was 0.8%. Notably, 2 cases of ILD were reported, and one was grade 1, one was grade 2, and one was grade 3, and no new safety signals was identified. Here is my conclusions. Iza-Bren and 2.2 and 2.75 milligram kilogram D1 date Q3 strategy in combination with Osimertinib as first-line treatment showed a tolerable and manageable safety profile in patients with EGFR-mutant treatment-naive metastatic non-small cell lung cancer. And the common treatment-related adverse events were hematological toxicities, and the preliminary anti-tumor activity of Iza-Bren combined with Osimertinib was really encouraged, especially in patients who received at the dosage of 2.5 milligram kilogram cohort. The objective response rate was 100%, with confirmed objective response was 95%. And also the phase 3 study of Iza-Bren in combination with Osimertinib in first-line treatment for EGFR-mutant treatment-naive non-small cell lung cancer is also ongoing in China. Thanks for your attention.
Thank you very much. 2 very excellent abstracts. We're going to shift gears a little bit now and think about AI, large language models, and machine learning, and how these apply to early detection. And very excited to have Dr. Mary Pasquinelli from the University of Illinois at Chicago here today. Mary is the director of the lung screening program at UI and a certified tobacco training specialist. Mary will present today on abstract 829, validation of Sybil in a minority population, results from the Sybil implementation consortium. Welcome, Mary.
Thank you. Thank you very much. Let me go to the next slide. So Sybil is an AI deep learning model developed by MIT and Mass General Hospital. It is a model that can analyze one low-dose CT and predict an individual's future risk of lung cancer at year 1, year 2, all the way to year 6. It requires no clinical data such as age or smoking history and no manual annotation. It's an open source algorithm free to download. Sybil was trained on the National Lung Screening Trial, which was 91% and only 4.5% Black or African American participants. And published studies, we know that lung cancer risk varies by race. So the aim of our study was to validate the performance of Sybil in a diverse high-risk lung screening cohort at UIC UI Health. UI Health is an academic safety net hospital that serves minority populations from low socioeconomic communities on the south and west side of Chicago. The lung cancer diagnosis rate in our screening program is approximately 3%, significantly higher than the National Lung Screening Trial at 1.1%. Here are some of our demographics. 66% were non-Hispanic Black individuals, 16% non-Hispanic white, 14% Hispanic, and 4% Asian. 63% of the participants were currently using tobacco at the time of the low-dose CT, their baseline scan, and 54% were male. So we retrospectively applied Sybil to 2,092 baseline low-dose CTs from our screening program from 2014 to 2024. All of them met the USPSTF eligibility criteria. 68 participants developed lung cancer within the program. And since we started the program over 10 years ago, we prospectively collect demographic and exposure history collected at each scan, and then scan results, demographics, and pathology is updated on a weekly basis and stored in REDCap. So here are our results. Sybil works really well in our population. Let me walk you through this figure. So on the left, this is the ROC curves. The panel on the left are all the participants, 2,092. And panel B on the right are non-Hispanic Black individuals, which was a subcohort of 1,291. The dark line at the top of each curve is the AUC at 1 year, and the lighter lines are years 2 through 6. An AUC of 1 indicates perfect ability to distinguish high versus low risk cases. These curves are nearly identical, with Sybil achieving excellent discrimination at year 1 with an AUC of 0.94 and maintaining good predictive value at 6 years with an AUC of 0.79. So this graph represents the 68 lung cancers diagnosed after their baseline low-dose CT. 35 cases were diagnosed within a few months to a year after the baseline low-dose CT, most likely due to radiographic findings on the CT. But importantly, 29 cases, or 43%, was diagnosed from year 2 through year 6 after that baseline CT. So Sybil had already identified these cases as high risk, and this highlights Sybil's potential to pre-diagnose lung cancer years before it becomes evident on the CT scan. So we want to be sure that Sybil works well in all races. This graph compares the UIC cohort on the right to other validated cohorts that are on the gray bars. On the left side is the National Lung Screening Trial and the Mass General cohort, which were screening cohorts, and the majority of those individuals were white. In the middle, we have East Asian cohorts of Taiwan and South Korea. And what's interesting about this population, it was a mix between those who had a tobacco history and those who didn't, and then UIC. And you can see the AUC range from 0.95 to 0.86, demonstrating consistent, strong predictive performance across diverse populations. And it is very important when new AI algorithms are introduced, they are assessed for performance on a variety of populations. So in conclusion, this real-world validation, Sybil is working very well to predict the future risk of lung cancer, and it was consistent against different racial groups, suggesting minimal bias. The Sybil Implementation Consortium is leading prospective trials to evaluate Sybil integration into clinical care pathways. I just want to take a moment to talk about the Sybil Consortium. It is led and developed by Alicia Sequist at Mass General Hospital. There's 4 sites. I'm running the UIC site, and Baptist is led by Ray Osimertinib, and then Bill Mayfield at Wellstar. And we meet every week to talk about Sybil implementation in the United States, and we work with our Sybil global partners quarterly. We have 2 prospective trials that are funded, one by AstraZeneca looking at pulmonary nodules and one by Lilly looking at implementation in the lung screening cohort, even outside of the USPSTF guidelines. And just a couple thoughts about future implementation or implications is that possibly Sybil can be used to tailor lung screening intervals based off of the Sybil score. It also could possibly be used for personal population screening studies, such as what we do for colon cancer screening in the United States, where everyone at a certain age has a baseline low-dose CT, and then based off of those scores, we individually tailor when they should come back. Maybe they don't need another scan or come back in 6 years, sometimes 3, maybe 3 years, or if it's high risk to come back in a year. And then there's this possibility that I'm really excited about of doing preventative trials. If we can pre-diagnose a lung cancer, we can do preventative trials to prevent that lung cancer from developing. So there's a lot of great work happening in the AI and the Sybil Implementation Consortium. So with that, I want to thank our Sybil Implementation Consortium team, my co-authors, AstraZeneca and Lilly for funding us, and also all the healthcare providers that engage their patients in screening and individuals who participate in screening. Thank you.
Thank you, Dr. Pasquinelli. Very compelling data. Excellent presentation. We'll definitely be watching that space. Next up, we have a presentation of new data from the Compel study by Giuliana Pacello. Dr. Giuliana Pacello is an associate professor at the University of Padova in Italy, and she will be presenting virtually today. And her abstract is 1174 Compel, Osimertinib plus platinum-based chemotherapy in patients with EGFR-mutated advanced non-small cell lung cancer and progression on Osimertinib.
Thank you very much. Good evening. My name is Giulia Pacello. I'm a medical oncologist from the University of Padova and Veneto Cancer Institute in Italy. And I'm pleased to present on behalf of all co-investigators the first results of the Compel study. Osimertinib in combination with platinum-based chemotherapy in patients with EGFR-mutated advanced non-small cell lung cancer and non-CNS progression on first-line Osimertinib. So a short background behind the study design. We know that Osimertinib is the third-generation EGFR TKI currently used as first-line treatment in this patient population, and that platinum-based chemotherapy is a standard treatment option at the time of disease progression. So the biological rationale behind this Compel study is that the progression on first-line Osimertinib is sometimes heterogeneous, with some cells, especially within the CNS, retaining EGFR signal independence and sensitivity to EGFR TKI. So considering its CNS activity, Osimertinib may continue to exert a protective effect in the CNS, also following on CNS progression. So the combination of Osimertinib plus platinum-based chemotherapy has already shown a manageable safety profile and is currently a first-line treatment option in this patient population, thanks to the results of the FLAURA2 trial, while the Compel study explored whether Osimertinib plus chemotherapy improves the outcomes versus placebo plus chemotherapy following non-CNS progression on first-line Osimertinib. This is the study design. Compel is a global randomized phase 3 double-blind study in patients with EGFR mutant advanced stage non-small cell lung cancer with or without brain metastasis and progressing beyond the CNS to first-line Osimertinib. 98 patients were randomized 1-to-1 to Osimertinib or placebo in combination with the platinum-based chemotherapy in the induction as well as in the maintenance phase with pemetrexed until progressive disease or other discontinuation criteria, and the randomization was stratified by the presence of CNS metastasis at the study entry. The primary endpoint was the investigator-assessed progression-free survival. Secondary endpoints are CNS progression-free survival in patients with and without brain metastasis, non-CNS progression-free survival, and overall survival. And chest and abdomen, as well as brain imaging, was mandatory at the baseline and through treatment cycles according to the protocol procedure. I want to specify that the Compel study was initially designed planning to randomize 204 patients, but then considering the treatment landscape changes, the sample size was reduced and the study was not powered to formally test a statistical hypothesis, so a descriptive analysis of all efficacy endpoints was performed. Here, the patient's characteristics well balanced between the two arms. We observe a lower percentage of females and a higher percentage of exon 19 deletion in the OSI plus chemo arm. And the patients with brain metastasis at the baseline represented 22% of patients in the OSI plus chemo arm and 24% of patients in the control arm. This is the primary endpoint in all randomized patients. Progression-free survival was longer in patients receiving Osimertinib plus chemotherapy with an hazard ratio of 0.43. Median PFS was 8.4 months in OSI plus chemo arm and 4.4 months in placebo plus chemo arm. 76% of data maturity. And 6 months PFS rate was 64 and 32% in each arm respectively. Here you can see the non-CNS PFS. Also in this case, in all randomized patients, hazard ratio was 0.43 with a longer PFS non-CNS in the experimental arm, 8.4 months compared with 5.2 months in the placebo plus chemo arm and 6 non-CNS PFS rate of 65 and 35%. Here you can also see an exploratory post-hoc analysis of the overall response rate, non-CNS, so extracranial overall response rate that was 35% in the OSI plus chemo arm and 29% in the placebo plus chemo arm with a median non-CNS duration of response of 8.2 versus 4.2 months. Among patients without baseline CNS metastasis, CNS progression-free survival was also longer in the OSI plus chemo arm with 15.9 months compared with 8.6 months in the placebo plus chemo arm and an hazard ratio of 0.56 and 6 months CNS PFS rate of 87% and 63% in each arm. Here, we do not report the CNS PFS for patients with stable CNS metastasis at the baseline because of the very small sample size. However, I can say that the 6 months CNS PFS rate also in this small subgroup was 82 and 56% in arm A, Osimertinib plus chemo, and arm B, placebo plus chemo, respectively. At the time of disease progression, 10% of patients receiving OSI plus chemo developed new brain lesions, compared with 27% in patients receiving placebo plus chemo. And finally, the secondary endpoint of overall survival with the 55% of data maturity. Median overall survival was 15.9 months in patients receiving Osimertinib plus chemotherapy, compared with 9.8 months in patients receiving placebo plus chemotherapy, with a reduction in the risk of death of 29% and 12 months survival rate of 67 and 37% in the two arms. The safety profile was already known for this combination of osimertinib plus chemotherapy with anemia, asthenia, and nausea as the more represented toxicity in both arms. So these are the conclusion. Results from the Compel study suggest continuing osimertinib as a backbone treatment for EGFR mutant advanced non-small cell lung cancer through lines of therapy, together with ongoing currently studies evaluating novel combination with osimertinib as a backbone treatment through lines of therapy. So I thank you for your kind attention.
Thank you, Dr. Paseo. Rounding out our research for today is an update on CheckMate 77T from Dr. Jonathan Spicer. Dr. Spicer is an associate professor at McGill University, medical director of McGill University's Center on Thoracic Oncology Network. His abstract today is 3305, patient-reported outcomes with perioperative nivolumab by nodal status in patients with resectable non-small cell lung cancer from CheckMate 77T.
Thank you very much. So on behalf of all the 717 investigators, it's my pleasure to present these patient-reported outcomes, specifically in the context of N2 status for patients with resectable non-small cell lung cancer in the context of the CheckMate 717 study. As you all know, the landscape of resectable non-small cell lung cancer has changed dramatically over the last few years with the introduction of neoadjuvant and perioperative regimens. 717 is one of those, with the addition of perioperative nivolumab to neoadjuvant chemo showing significant EFS benefit and PCR benefit as compared to neoadjuvant chemotherapy alone. And these data in the N2 patients were previously presented at ASCO. This is important because in the context of stage 3 N2 disease, we have multiple standards of care that are now emerging as reasonable options. One being the option of chemoradiation and adjuvant durvalumab, and then of course the surgical strategies, which include a number of IO agents before and after surgery. So the importance of understanding quality of life in this context is quite important. And so we specifically looked at patients with N2 or non-N2 disease using various measures of health-related quality of life, including a relatively novel concept of time to definitive deterioration in health-related quality of life. It seems that most of the benefit in terms of delaying deterioration quality of life was present in the N2 patients. But what's important to note is that both in the N2 and non-N2 patients, if you look at departure from baseline quality of life, other than the brief period after surgery, most patients remain within the non-clinically significant range, indicating that perioperative nivolumab did not harm these patients, in fact, provide benefit in a significant majority of them, and this was durable throughout the course of observation. This was both true in the symptom assessment questionnaires, but also with the visual analog scale assessments that found the same results. Looking at the impact of surgical outcomes, specifically the extent of resection and the completeness of resection, we see benefits in terms of time to definitive deterioration for patients who had a simple lobectomy, as well as those with complete resection. This was true both on the symptom assessment and visual analog scales. Unfortunately, well, perhaps fortunately, the number of patients with R+ resections or extended lobectomies were few, and therefore we could not generate curves to represent those patients for statistical reasons. So in summary, the data here on health-related quality of life indicate that this regimen is both safe and tolerable for patients with the best measures we have of quality of life assessment, and that this is both very clearly true in the N2 population, suggesting that a surgical course is an absolutely reasonable choice for these patients, for whom we now have very detailed health-related quality of life data going from the point of diagnosis all throughout the treatment course and beyond into the surveillance of these patients. So that's it. Thank you very much to all the patients and investigators who contributed to this study. Look forward to your questions.
really some very exciting research today. So thank you to all of our presenters. We'd like to close out today's briefing with patient research advocate Ms. Meryl Hennick today with us, and she's going to share some of the importance of this work from the patient community's point of view. Meryl is a historian, teacher, researcher, wife, and mother of two. She was diagnosed in 2014 with stage 4 ROS1 lung cancer, rare onco-driven subtype affecting less than 1% of lung cancer patients. She embarked on the journey of targeted therapy beginning with crizotinib in March of 2015, followed by lorlatinib since 2016. We're very excited to have you here today. Meryl also is the founder of a university course, Meryl's Werrells, and an active patient advocate. So go check that out. And ambassador for Lung Cancer Europe, representing the Dutch lung cancer community at global councils and conferences. And in 2025, she was appointed to the board of Lung Cancer Europe. Very excited to have you today.
Thank you for having me here. Every year when I go to World Lung, I become hopeful for all the breakthroughs, but also the passion of all the researchers and the clinicians and the patient advocates. Professor Peters just spoke about that the IASLC is her family. For me, it's my world. And for me, it's all the hope that I have for another treatment option and to have a life. And the first thing that we always look at is efficacy. What is the overall survival, progression-free survival? And this year, the study of Iza-Bren, a new ADC, was very promising for the survival rates, and it showed overall survival very high. The only thing is, if we're talking about manageable side effects, what is manageable side effect? Is that according to the theory, or is it according to what patients really think? And I think. And I applaud the PRO study from the Nivolumab, the neoadjuvant, because we only can choose our next line of treatment if we really know what the side effects mean and what it is how it impacts the patient's life and the quality of life. Because the balance between quantity and quality is personal. And it's not just, well, the overall survival is the best, this is the best treatment. We really need to see more PROs within the studies, but also in clinical practice, so that we can really have an informed decision if we have to choose a new treatment option. Another challenge is the access. In some countries, even patients have to do a copay to get chemotherapy. So if combination therapies can be very effective, but if a lot of patients cannot afford or cannot access it, then the inequity the gap will only widen. So, but I like to applaud the Sybil AI model. AI is for me still a little bit abracadabra, but if you can predict the chance of having lung cancer and the early detection, then I think that we are going 1 + 1 is 3. So yeah, I was very amazed by it. And the only thing is that the screening program in the country must be available. And in a lot of countries, the screening program is not available yet. Even in the Netherlands, where we had the Nelson trial, we still not have a complete screening program. And so that is also a collaborative action that we all have to take, that early detection is possible, so that fewer patients get the advanced stage diagnosis. And yeah, and the PRO was completely out of my heart, and I thought, yeah, this is what we need as patients. When we know that the health-related quality of life doesn't change when you take the Nivolumab, then we can count on it, and it's more reliable than when we just go, well, it's a grade 2, you can do it. It's manageable, because manageable, yeah, it's for every patient. Well, together, I know that together with all the researchers, advocates, policymakers, we have to make change so that access is for all, that we know that patients all have the treatment options that is accessible, and that we all live longer in a better quality of life. Thank you.
Thank you to our wonderful speakers. Thank you to the in-person audience and those watching online synchronously or asynchronously. We really appreciate your attention, and we're happy to take some questions today.
We have a mic here. You can pass it around if you have any questions here. If not, we'll field some questions from our online press via Zoom. Okay, let me step over here. And no other questions at this time. So
we've got one up here.
Oh, we got one. Oh, sorry, I missed that one.
Hi, I'm Minghua Lu from Yichang Health. A question for Dr. Wenfeng, Wenfeng Fang. So how do you interpret the clinical significance of this, clinical study, for the landscape of the EGFR mutant non-small cell lung cancer?
As we know, the standard of care for EGFR mutation non-small cell lung cancer, the third generation is the standard of care. But we know that all the patients will have disease progression, and after post-EGFR TKI and the standard of care for EGFR mutant non-small cell cancer is the platinum-based chemo, and the PFS is limited in like about 4 to 6 months. So there is a very huge need to explore the new drugs and new strategy. And from our study, we found that the EGFR bispecific ADC and the efficacy is very, very promising. And in the post-TKI and chemo-naive patients, objective response rate was 56%, and the median PFS was 12.5 months. To my knowledge, and this is the longest PFS has been reported up to date. And I think this result is very, very promising. And according to our study and this promising data, we already conducted a registrational study in EGFR mutant non-small cell lung cancer as post-TKI as a monotherapy. Now the trial is ongoing in China, and I hope this result will be positive and maybe to move this new drugs to be approved in China and maybe some days in all the world. Yeah, thank you.
Oh, excellent. All right, last chance. All right, well, thank you all for your attendance. Thank you. Please make sure you go check out these abstracts online, and see you back tomorrow. Thank you.